I've been conducting this course now for many years, and we do try and keep the content of it current and up to date. So we do change things from year to year. And so I think one point that I always make is that when you're looking at astigmatism analysis, you can look at it by looking at refractive values, but you can also look at it by corneal values. Because corneal values is very objective. You know, whatever the machine comes out with the answer, that's what the astigmatism is. Whereas manifest refraction is a little bit more of a rubbery figure. It depends a little bit on the patient interaction with the optometrist or the doctor in doing the measurements. And so it's good to have a parallel set of analyses by cornea as well as refraction. The second thing I think the message we'd like to get across is that just looking at the amount of astigmatism remaining compared to the amount of astigmatism you started with, that's an important parameter to know whether you reduced astigmatism, but it doesn't really tell you very much about the process, about whether if you don't get the perfect result, or what went wrong with this operation. Was the treatment too much or too little? Or was the treatment on axis, or was it off axis in a clockwise or counterclockwise sense? Because by looking at it that way, you can look at how you might do the next operations in a more successful way. And also you can use it as a scorecard, as we say, the difference vector, which is kind of an absolute way of determining which is the better mode of analysis. So that's on the analysis side of things. As far as the treatment goes, we certainly described vector planning, because that's something which is topical since Dr. Arbeles's paper. We talked about planning cataract surgery using toric implants. So we've developed a toric calculator that really addresses every question of how to best decide the parameters for a toric implant to correct an eye after cataract surgery, both for the spherical side of things and the astigmatic side of things, taking into account the length of the eye, the power of the implant, the effective lens position, and also we can even include with that calculator not just the anterior cornea but the total corneal power to determine best the power of the toricity of that implant. So we went through toric implantation, and that was also something which people can use, because we actually have a toric calculator on our website. We've got a toric implant calculator on our website that people can use for free. So the interesting thing about it is that when you're doing an astigmatic analysis, in most situations you compare preoperative cornea with postoperative cornea, and you compare preoperative refraction with postoperative refraction. But the thing that's different about a calculation of a toric implant is that the postoperative refraction is the important component, but it's based on the preoperative corneal astigmatism. So it's what you call a hybrid analysis. You do an analysis of the preoperative corneal astigmatism and do that vectorial analysis compared to the postoperative refractive cylinder. And so that's a little bit different. So we talk about how that might be applied to the people who come to the course. And then if you do get a surprise refractive result in the outcome, we have a refractive surprise calculator that tells you whether this implant, if you didn't get the result you want, can you just rotate this implant to a better position, or do you need to change the implant, or do you need to do LASIK on top to correct that refractive error, and how to go about deciding which is the best way to go. So the very gratifying thing about the work that I've done and the things that I've published is that there's been a recognition that my method, which we call the Alpins, which is called now the Alpins method of astigmatic analysis, is now been adopted by the major journals, which is the Cataract and Refractive Surgery Journal, Journal of Refractive Surgery, Ophthalmology, which is from the American Academy. They've adopted my technique of astigmatic analysis so that any doctors who want to publish their results on astigmatism can do it, they must do it using my technique, which is very gratifying. But furthermore, it's gone further than that. Even the FDA, through the ANSI standard, adopted my technique for the companies when they evaluate their devices to correct astigmatism. They need to give their results for the evaluation of the FDA using my technique, although they do use a slightly different terminology. I think the biggest step forward would be, and this is something which I think I'm promoting most of all, is the idea of bringing the corneal shape into the treatment plan, particularly for laser surgery, because historically, since the lasers were introduced back in 1991 or so, it's always been the idea that you use the spectacles as a cornerstone of treatment and not to address the question of the corneal shape. Even though you might look at the topography to ensure there's no keratoconus there, then you disregard all the numbers that come out of the topographer. And my concept would be that if we're corneal surgeons, we should be looking after the cornea in a more effective way by incorporating the corneal shape into the treatment plan. And by doing that, at the end of the day, you end up with less astigmatism on the cornea and consequently get better vision for it. Because with refractive surgery and even with cataract surgery now, the goal is to eliminate the need for glasses. So the patients, in almost all cases, throw away their glasses, but they have to wear their corneas for the rest of their lives. They have to look through those corneas for the rest of their lives. And so if you can have a technique that leaves you with less corneal astigmatism without any compromise to the refractive result, then that's a big step forward, because less is more, really. If you can end up with less, it's kind of, you get a more of an effective result.